We are a group from Ball State University doing mm, an ethical debate on standardizing evidence-based treatments with Mackenzie Bly, Leah Fleming, Diana, Lauren, Keith, and Krista.
All right. So to start us off, standardization is useful in the ABA practice to provide guidelines for assessments, effective evidence-based treatment interventions, and training staff, and this will be discussed in our presentation. There are some limitations to the standardization of the ABA practice, which includes being limited to certain behaviors and cultural practices that may not meet the needs of everyone that will be discussed throughout the presentation. On the next slide, I am going to go over the pros for ABA practice. Oh my God. Where did my notes go? Sorry, guys. ABA is an evidence-based treatment. ABA is also known as applied behavior analysis. It teaches children as young as 18 months old the life skills that they will need to function in society. It has been shown to be helpful in boosting independence, lowering problem behaviors, as well as improving social interaction. It uses a range of tactics such as modeling, reinforcement, and realistic teaching strategies. Evidence-based treatments like ABA, according to the American Psychological Association, can enhance quality of life for up to 72% of people with developmental disorders. ABA, also known as applied behavior analysis, as I said, is an evidence-based treatment approach based on the principles of operant and classical conditioning. This form of treatment teaches life skills and new behaviors in specific settings through the use of positive and negative reinforcement or punishment, depending on the client's skill level. ABA has a number of techniques that can be used to teach various skills. In an effort to provide a brief overview, I will highlight three essential elements that ABA covers. That is verbal instruction, modeling, and social environments. The first thing that behavior analysis should do is conduct an intake eval or assessment of a client to determine what would be the most beneficial for him, her, or them. Behavior analysts should also have an individualized functional analysis that outlines various environments, events, and stimuli encountered by a client that may cause behavioral issues. This will help them develop an appropriate intervention plan, and a properly prepared environment can be very beneficial for these clients by reducing their risk of having safety related incidents such as escape attempts and injuries. The three elements, as I discussed, one is verbal instruction. It is the way ABA can help clients by encouraging verbal instruction. This use of ABA techniques allows the client to learn new skills through verbal instruction rather than physical or physical prompting, elicitation, and it can be very effective because it avoids the need for physical contact and raises their self-esteem. It also improves communication and interaction with others. The next level that ABA uses is model behavior. It teaches clients through modeling, which involves using an actual example to help the client perform a task on their own. Modeling is a method that can be used by an individual to demonstrate how to perform a behavior and improve their ability to learn it on their own. The more modeling, the more positive reinforcement and self management skills that can be acquired by children. Communication is the last point I'm going to make. It is a safety based intervention that can encourage better compliance with behavioral goals. The most common form of communication is verbal. Behavior analysis will use praise and reinforcement when they notice a client exhibiting strengths or making progress towards their goals. This can be very motivating to a client or a caregiver and help them see that he or she or they are making progress, and it will result in positive outcomes such as enjoying new privileges. In addition, it makes behavior analysts try their best to increase the chances of success when they conduct any type of communication with clients. If a client is unable to express his or her needs verbally, then they must find other types of communication, such as movements or gestures to communicate. They can also use devices or PECs. And Leah will be taking over on our argument against standardization.
Okay, so my name is Leah, and I will be arguing against standardizing evidence-based treatments. First, I'm going to discuss a little bit about what evidence-based practice is. There have been a couple different definitions of what evidence-based practice in ABA is. Smith in 2013 described evidence-based practice as a package of procedures that are operationalized in a manual and that have been validated in studies and shown socially meaningful outcomes. However, Smith's definition is lacking a few crucial components. Slocum and colleagues in 2014 came up with a new definition of what evidence-based practice is. They described it more as a decision-making process that integrates the best available evidence along with clinical expertise and client values and context. If we only focus on the evidence-based treatment, we're missing part of the process. In Ethical Code 2.14, selecting, designing, and implementing behavior change interventions, this code discusses evidence-based practice as well. So this code, it discusses when behavior analysts are selecting, designing, and implementing behavior change interventions, ensuring that they are consistent with behavior principles based on scientific evidence, based on assessment results, prioritizes positive reinforcement procedures, and that it also best meets the diverse needs, context, and resources of the client and stakeholders. If you want to move to the next slide. Now that we know a little bit about what evidence-based practice is, I'm going to argue why we are against standardizing evidence-based treatments. I want you to think about when you're working in the field and you come across a clinical problem when working with your clients. The first thing a behavior analyst may do is go to the research to identify an evidence-supported treatment. Once they find an evidence-supported treatment for their clinical problem, they figure out how to implement it by following a treatment manual. But what happens if the evidence-supported treatment doesn't work with their client and there are no additional guidelines in the manual? Then what does the clinician do? What if this evidence-based treatment was effective for one of their clients, but not a different client? Do you just go back to the research to find a different manual for a different treatment? One example in my personal clinical experience is the PECS manual, which many of you may be familiar with. This manual provides different steps that a clinician can follow to implement this communication system with their clients. While this is a great resource to have and provides a starting point for implementing this communication system, I will say I very rarely follow the manual step by step without making some sort of changes to individualize it to my client's needs. Another example that may be familiar to many of us is the introduction of conducting telehealth sessions that occurred due to the pandemic. When we got the word that we were able to conduct telehealth sessions with our clients, there wasn't a manual for that. We couldn't go to the research and determine the most effective way to conduct telehealth sessions, but we had to figure it out. There's not going to be a manual and standardized procedure for every single scenario and every single treatment that we use with our clients, but we can use our clinical expertise, our knowledge of behavior principles, and our knowledge of evidence-based treatments to help guide our practice. We're not here to argue that we should not use evidence-based treatments in our practice. We're here to argue against the standardization of evidence-based treatments. Standardizing evidence-based treatments will lead to a cookbook approach in which clinicians only learn how to treat a clinical problem in the same way, are unable to problem solve or troubleshoot problems that may occur when implementing treatment, along with clinicians failing to learn about new and more effective treatments that may arise in the future. We owe it to our clients, their families, and the autism community to avoid a standardized approach to treatment. Now next, Mackenzie is going to discuss the standardization of assessments.
Okay, so I'm going to be arguing for the standardization of assessments. So evidence-based ABA practices have been implemented for people with autism across decades. ABA procedures focus on specific socially significant behaviors that are clearly defined and replicable. So some ethics codes that relate to pushing the standardization of assessments would be 2.13, selecting, designing, and implementing assessments. Evidence-based treatments have been tested across various settings and people to show evidence of generalization of the intervention. Standardizing specific behavioral assessments or interventions can reduce that broad scope to set a clear and easily consumable treatment package. One standardized assessment that I'm going to be discussing is functional behavior assessments. And just to give a background on those, people with autism typically engage in behaviors that are maladaptive, which may include self-interest behavior, aggression towards others, elopement, and tantrums. ABA therapy looks at behaviors from a function, meaning the consequences, versus the form. So this means that behaviors can be replaced by meeting the function, which may include attention or to escape a task or aversive environment or to gain access to a tangible item or activity. Functional behavior assessments are used to help determine the function of maladaptive behaviors in order to write a behavior plan that meets the needs of the individual using replacement behavior. Functional assessments are conducted differently depending on the client's needs and the behavior analyst's experience. So since they're conducted differently, a board certified behavior analyst working with a child with autism is not guided by a designated set of widely accepted practices, which means similar cases may be treated differently depending on the BCBA and their training. Standardizing specific behavioral assessments or interventions can reduce that broad scope to a set of clear and easily consumable treatment package. Another ethics code that is useful for the standardization of assessments would be providing effective treatment. Behavior analysts rely on scientifically and professionally derived knowledge when making scientific or professional judgments in human service provision or when engaging in scholarly or professional endeavors. So this means behavior analyst always has the responsibility to recommend scientifically supportive, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients and society, and clients have a right to effective treatment based on the research literature and adapted to the individual client. So a personal experience I've had with, first I'm going to also talk about the steps that need to be standardized for a functional behavior assessment. So that could include having multiple test conditions, being attention, escape, and alone, using uniformly applied procedures in each condition, using isolated reinforcement contingencies, and a play or omnibus control condition attempting to control for all assessed contingencies in the distinct test conditions. An ethical dilemma I have experienced in relation to Ethics Code 2.13, selecting, designing, and implementing assessments with a family from a different cultural background who had different thoughts on their child eating with their hands or with a fork or spoon and never taught their 4-year-old child how to eat with a fork or spoon. So when the assessment asked a question about whether or not they could eat with a fork or spoon, the assessment technically stated they were delayed in this area, where in this case it showed the child was delayed even though it was for a cultural reason and may have not been actually had to do with a delay. And to close out, Lauren will be talking about alternative assessments that are not yet standardized as the counter argument.
Hi, I'm Lauren, and I am here to talk about being the con prover and talking about alternative assessments that can meet the needs of clients that are not yet standardized. I apologize if my face comes out of the screen. Something's going on with it. So I presented a list of multiple unestablished interventions for individuals under the age of 22 and for individuals that are older than the age of 22 that I found through the National Autism Center developmental journal. So let's see. There's a large number of interventions and therapies that are not yet evidence-based, yet are still commonly used to help support people with autism, and some of them are still even commonly used within ABA. The National Autism Center developed a journal called Findings and Conclusions, National Standard Project Phase 2, that looked at all current interventions and treatments for people with ASD and concluded whether or not the interventions were established or unestablished based on how much scientific evidence and literature had been developed. According to this particular journal, the different ones that were in their standardization were unestablished, were animal-assisted therapy, auditory integration training, concept mapping, DIR or floor time, facilitated communication, gluten-free or casein-free diet, movement-based intervention, sense theater intervention, sensory intervention package, shock therapy, social behavioral learning strategy, social cognitive intervention, social thinking intervention, and the VB MAP assessment. The unestablished interventions for adults were cognitive behavioral intervention package, modeling, music therapy, sensory integration package. So I discussed in the next slide, and the following slide as well, some common alternative assessments and alternative interventions that are commonly used within ABA as well as out of ABA. Floor time, although not necessarily called floor time in ABA, is a therapy used for children with autism. The intervention is used on getting down on the floor, playing with a child, and doing one-on-one interactions with them at their level. This can be used both with therapists and parents, and is commonly used in order to interact and pair with children. Another one is called movement-based intervention. Although not commonly used in ABA, it is a intervention that shifts the attention from perspectives that focus just on solely on deficits in ABA or in children with autism in general towards more of an embodied perspective. So they focus a lot on stretching, moving around, jumping, spinning, dancing, all of these things that can kind of get children interacted from what I have observed in the past in my own findings and my own observations of this type of intervention. It is a way to get children to interact with you and to learn different things in their natural environment based on moving their bodies. On the next slide, there are a couple of other alternative assessments. Although not used currently in ABA, animal-assisted therapy is a very common therapy that many people with autism typically interact with, whether that be canines, other animals, and now equine-assisted therapy has been becoming more of a prevalent therapy that is being used. And these assisted therapies typically help with myriad of different things, such as being able to work on their body movements, working on social skills, working on vocational skills that they will later learn with a job, and also being able to interact with different situations. And this is a very common therapy. Another one is concept mapping therapy. It helps generalize new skills, makes abstract concepts more concrete, enhancing the processing and retention of thoughts. By using visuals, and some of the examples that I placed in this PowerPoint here are some very large scaled um, concept mapping, and is something that um, is used in order to help with people who are more visual learners. And I believe next person to speak is
Hello, everyone. My name is Diana Indelicato. So my topic for this presentation is the pros of training staff and standardization. So this topic actually is very relevant to my current placement. I'm a special education teacher in an ABA approach classroom. So all of my students that I have are on discrete trials. So and in my classroom I have paraprofessionals that I train and manage. So with that, it's really important um, to make sure that everyone is on the same page, because standardization in human service staff ensures that delivery of behavioral interventions are the same, and it promotes treatment fidelity. So if everyone is teaching it the same way to the student, the more quickly and the faster that the skill being taught could generalize across multiple people and settings. And training staff in one specific way ensures that interventions or skills meant to be taught to recipients of the intervention demonstrate the desired response. So in my case, in my school, the concept of teaching students more and less. So I would teach paraprofessionals how to run this program the same way, the same to each paraprofessional, so that the student emits the target response across them, so that the skill is hopefully mastered rather quickly. Standardizing training staff adheres to the BACB ethics codes 4.06, providing supervision and training. So it's really important. I feel that there should be a set framework for this, especially for the people that are working with our clients and students wherever these individuals are receiving these behavioral services, just so that there's a high quality of service delivery, and that the clients and students get the best therapy that they deserve. So with that, Keith will be discussing the cons of standardization of training staff. I think you're on mute, Keith.
Keith, I believe you may be on mute.
Okay, everyone. Sorry about that. So I am against the standardization of training staff. ABA programming and interventions are unique and should be designed for each individual. So should staff training. You're not going to train an individual with ASD on a task that they can already accomplish. ABA staff training is not a one-size-fits-all concept. Training staff should never be done only one way. According to Luesi et al. 2008, no single training procedure is effective. Staff require training packets to learn effectively. While some staff will have certain training materials in their packet, other staff will have training materials necessary for them to learn the material. Training ABA technicians should be individualized. According to DeBoth and Dominowiski, 1978, there is a general belief that some students learn better using auditory presentation, while others learn better from visual presentation. Some use a combination of both. Therefore, you cannot have standardized staff training when there are different types of learners. And I just wanted to kind of put out a real world example. I know my daughter in school, when she's getting ready to take a test, the teacher will allow her to go into another room, and the teacher will read the questions to her instead of her having to read the questions herself. That's just how she learns better, from hearing the questions instead of having to read it herself. So that's why I'm really against the standardization of staff training. Next up, for the remaining points and to give us a summary is Krista.
Thank you, Keith. To summarize the pros and cons of standardization, to start, I will go with the pros. Standardization of ABA practices is in fact useful for providing effective treatments, for providing assessments for effective treatment, and to train staff members. For providing effective treatment, standardization is crucial for selecting treatments that are evidence-based and have been proven to show changes. Standardization is important for assessments to allow behavior analysts to provide the same style of intervention to clients with similar behaviors. Training staff members uses standardization to provide the same intervention across providers to ensure that the treatment is in fact working. As far as against standardization, our summary of this is standardized assessments are not individualized to each person, and some interventions that are more individualized may or can benefit an individual based on that person's needs and their learning abilities. These are our references. And our references continued. We hope you enjoyed our debate.